I set my timer so that I will try to be on time this time. So thank you again. This is a lecture I appreciate a lot because we need to share our impressions about the new guidelines. The new guidelines, in my opinion, are completely different. They want to share a completely different vision for the treatment of differentiated thyroid cancer. And that is really fascinating, especially because we have a really different scenario from several years ago. We see that diagnosis of thyroid cancer has increased in an incredible fashion because of several different factors. The main ones are the extensive use, the excessive, let me use the term excessive use of ultrasonography, and an excessive use probably of a screening that has no reasons to be done, and that is basically forbidden by the WHO right now. We see from this slide, we can appreciate how the diagnosis improved differently in different countries. We start with South Korea, where we know that it was developed a screening that led to an enormous amount of increased diagnosis of thyroid cancer. But we see that also USA and Italy has an enormously increased incidence of papillary and follicular thyroid cancer. Whereas India is a virtuous place where your diagnosis of differentiated thyroid cancer is what is needed. I mean, you diagnose those who are needed to be treated, probably. And this is a slide that explains it very well. Let's see what happens in Italy, where up to 70% of diagnoses are incidental, and in India, where just the diagnosis has been performed in a clinical way. So we need to start first with two separate things: the guidelines for the management of thyroid nodules that are incidentally detected by ultrasonography, and the guidelines for the management of those nodules who reveal to be thyroid cancer. This is the key point of these guidelines that I want you to show that have enormous differences from the past ones, because they are split. The 2025 guidelines for the management of thyroid nodules will get out soon, probably soon, and the 2025 guidelines for the management of thyroid cancer has finally arrived. So in the 2015 guidelines, those two aspects were all together, and the guidelines were very difficult to read and to interpret, and now they have split the guidelines in two separate pathways. I will start with the management of thyroid nodules, which is of key most importance for the diagnosis. As you can see, Bethesda 3, 4, 5 are included in the guidelines for the management of thyroid nodules, and the Bethesda 6 are not included because they are in a separate way. Estimation of risk of malignancy in a diagnostic nodule, in a nodule that has been ultrasonography diagnosed. Okay, the risk of malignancy was interpreted following a US atlas, but this atlas has been discussed a lot, and a lot of issues have been found regarding the American guidelines. So this was because 20% of 8% of the nodules cannot be labeled in the former atlas, and 20% of these were papillary thyroid cancers, which meant that a lot of work was needed to better address the workup of a thyroid nodule that have been diagnosed ultrasonographically. What will change is that the atlas needs to be expanded so that we can find a photo of our nodule. We can find more photos of nodules in the atlas so that we can compare better with our patient, the patient we have under our probe. So we needed to expand the atlas, and it was needed to use an algorithm as well. The atlas is now much more rich, and the algorithm is much more complicated. But we can use it as a manual. We can always find it easily on the internet. We can check. We can really use the guidelines as a manual for what we have to do right now. Just a few words. There are suspicious features, and these suspicious features will be of some help together with the nature and the composition of the nodule to determine those who need to be aspirated. So we are talking about selective aspiration of the nodule. This is something that we need to digest, because it's not easy to tell a patient who has a 1.5 centimeter nodule that he should not aspirate the nodule. We all know that the patients want their nodule to be aspirated, and we need limits. Very often the patients don't understand limits. So we needed a range of limit where to deal, where we can talk to the patient about what to do and what not to do. Meaning, we will limit our FNA to nodules over 1.5 centimeters if the nodule is highly suspicious, but we can talk about puncturing it in 1 to 1.5 millimeters limit, within this limit. Intermediate suspicion nodules and low suspicion nodules can go upper, we can find upper limit. So we can talk about puncturing them over 2 centimeters. And that is extremely reasonable. But really, we have to deal with a patient who is often very anxious to have his nodule punctured. When to re-punction again a benign nodule? Never, if the nodule does not change. So this is something that needs to be addressed. Don't punction any benign nodule if it doesn't change. This is extremely reasonable, I think. In the guidelines for differentiated thyroid cancer, we see we have a different philosophy. We have strong recommendation, moderate recommendation, and conditional recommendation. Conditional recommendation is a new entity that has been introduced and depends on the attitude of the expert seeing the nodule and diagnosing the nodule. Conditional is something that is generally, it cannot be proved, but is accepted, is generally accepted in the clinical activity, in the clinical activity of everyone. A lot of should have been modified to may and vice versa. So in the American guidelines, these two words are really important. And we'll see why. We have the different philosophy starts from this framework. We move into a DATA framework. Diagnosis, assessment, treatment, if there is a treatment, assessment again. So let's keep in mind that this is the way we should move. we don't need to go into a treatment immediately. We need to assess the risks and morbidity, mortality, and whatever. As for extent of thyroidectomy, a few words, just be sure that total thyroidectomy should not be performed anymore. It is not included anymore in our scenario. Lobectomy is included, and near total or total thyroidectomy can be a solution in most of the cases. First of all, we need to relearn histology again. So it's like, sometimes it's like learning the names of the new drugs, of the new TRKI. We need to learn NIFT-P, it's the newer entity, invasive encapsulated follicular variant of PTC that is going to replace follicular variant PTC. So they want us to keep up to date and to confuse us, but we will learn in the long run. We will learn also these sort of new acronyms. NIFT-P is the new entity. NIFT-P is definitely not an aggressive tumor, so we should treat it as it is. Let's not say a benign tumor, but it's somewhere in between. Obviously, it has been stressed that surgical experience influences complications rates for thyroidectomy. Again, what is the threshold? It's pretty unclear, but we will stuck to our 30 thyroidectomies per year threshold, which is reasonable. Should preoperative somatic genomic testing be done preoperatively in an undeterminate or a malignant nodule? And the answer is no. But we know very well that a lot of people arrive with the genomic testing already done. So we just keep in mind it. It might be useful, but afterwards. We generally don't use it for diagnostic or prognostic, as a prognostic factor right at the immediate start of the workup. The idea is that a lot of thyroid cancer should have not been diagnosed. So we have to identify those who can undergo active surveillance, those that people have, that are reported in autoptic cases. Up to 10 to 15% of the old autoptic series showed a papillary thyroid cancer in the thyroids, in patients who died for other stuff. So we need to identify those, and those are probably very well identified by ultrasonography right now. The question is, active surveillance should be limited to less than 1 centimeter nodule, but we're told that they should have not been FNA'd. So what's the point? This creates a lot of confusion. So for entering an active surveillance protocol, you need to punction a micronodule. We will see what happens in the future. But nevertheless, you can diagnose small carcinomas. I won't call them microcarcinomas anymore, because microcarcinomas, in my opinion, do not exist. Carcinoma less than 1 centimeter anymore, but I should do it to include them in an observatory protocol. Better than that, do you think we can ablate an 8 millimeter or 7 millimeter cancer? My answer is absolutely yes. We use thermal ablation for large nodules with great results. And in my opinion, why cannot we burn a much smaller nodule of 7 millimeters, if it is a cancer, we can obtain a perfect limit, a perfectly focused destroying of the nodule. That is, in my opinion, that will be the perfect indication for thermal ablation. So it's been years now that South Korean studies, Japanese and Chinese studies has gotten out with the evidence that active surveillance is safe. When to stop active surveillance and operate nodules? When they grow. Ultrasonography is the perfect tool to show aggressive and different behavior than expected. So for small nodules, ultrasonography can very well describe the activity, the biological activity, in my opinion, of the nodule. But, there is a but, the patient with the diagnosis of cancer generally is reluctant to keep it in his neck. So you might propose active surveillance, the patient goes to the hospital in the near to you, and they will tell him, oh, did they wanted to not to remove your thyroid cancer? And they operate on him. And the patient gets out from your observation. Again, when to operate when there's the evidence of an evolution in the nodule. So we are we're moving a scenario where we know that up to 70%, for example, and this is Italy, up to 70% of our patients are overdiagnosed. Can we propose a treatment that is less aggressive than what we used to do years ago? Okay, the patient wants the cancer took away from the neck, and I should propose a surgery to make him fit and not worried about his cancer. Lobectomy is now the standard of treatment, for sure, for patients under 1 centimeter if we decide to operate on them. But also for tumors less than 2 centimeters. So the guidance tells us lobectomy becomes the procedure of choice for tumors up to 4 centimeters. The operation should be a thyroid lobectomy. Maybe was in the past guidelines, should be is in the actual guidelines. What about in between 2 centimeters or 4 centimeters? We all know that we have, if we have a 3 centimeters nodule, we would be a little bit worrisome leaving one lobe behind. We would not be not worried. We might want to perform a total thyroidectomy. But we all know that when aggressive features are present, you see them. You very often see them. You explore the lymph nodes and you find big lymph nodes, even if the radiologist didn't tell you before surgery. You find that they are infiltrating the surrounding structures. You find that they are stuck to the trachea. So you can easily discern when to perform a total thyroidectomy. I mean, this is true for experienced surgeons. So what do I do with my patient? I always propose the patient for lobectomy. But I also tell, okay, this is a contract in between us, that if I see something aggressive, I will perform a total thyroidectomy and central neck dissection. And we all know very well that in very aggressive cases, we can recognize aggressive cases. Lobectomy can be done. For tumors over 4 centimeters, clinical lymph node metastasis or distant metastasis, there is no point discussing. Total thyroidectomy, central neck dissection, lateral neck dissection when there are metastases. We do not perform prophylactic lateral neck, but we can perform prophylactic central neck dissection. One small point, you can, when you perform a lobectomy, you can take away your central homolateral compartment, the nodes of your central homolateral compartment. But we will see later on that this is forbidden now. So, improving the lobectomies, we all know that we will improve completion thyroidectomies. Completion thyroidectomies will be needed in several cases, up to 20% of cases, but again, 2 lobectomies are better than 1 single total thyroidectomy that is complicated. It is worth the risk, and all patients know that they can undergo a second surgery, but a second surgery is not necessarily performed immediately after the first. So we can check the patient. We can DATA, diagnosis, assessment, treatment, assessment again. Let's wait. Don't rush. Follow-up is mainly performed through ultrasonography. Believe it or not, the new guidelines include a few words about thyroglosal duct carcinoma, which is an entity so rare that I think that in this room we might have 10 cases overall. Central neck dissection. How about central neck dissection? Prophylactic central neck dissection is not included anymore in the guidelines. So I always try to take away central neck lymph nodes. During my surgery for thyroid cancer, I should stop it. Believe it or not, I should stop it. And I want to stop it. I will try to. Not sure if I will do it. Intraoperative monitoring has changed completely over the past 10 years, so it is well included in the guidelines. And it is clearly written that intraoperative monitoring can and should be used in patients with thyroid cancer, especially to tailor the extent of surgery. So you lose the signal on your first nerve, you stop the operation. Again, believe it or not, that the guidelines tell us that we should not drain our thyroidectomies. I mean, this is a little bit absolute. It's not recommended, but sometimes I used to put a drain. I used to, and sometimes I want to put a drain. It gives me a false sense of security overnight, and I sleep well, but I sleep better, for no reason at all, obviously. We all know that IgA, TNM is still a poor predictor of recurrence, so here there are the ATA risk of recurrence. Low risk, intermediate low risk, up to 15% of risk of structural recurrence, intermediate high risk of recurrence. What is new is that they added a separate classification for follicular and oncocytic thyroid cancer, which oncocytic are much more aggressive than follicular thyroid cancer. High risk of recurrence. What's new? Tumor focality becomes an issue. We never considered it, but we should consider multifocality as probably a prognostic factor. Vascular invasion is a totally different thing. I mean, we should separate vascular in terms of angio invasion and lymphatic invasion. Angio invasion is much more severe and much more predictive of recurrence and distant metastasis. Lymph node yield, so the number of lymph nodes, this is something that as a surgeon we like. I removed 100 lymph nodes. We love to talk in these terms. And this is something that for thyroid surgery has never been accepted and is now accepted is now taken in count. Let's say taken in count, as well as lymph node ratio, the number of lymph nodes of metastatic nodes over the total number of lymph nodes. Extrathyroidal extension has changed a little, so gross extension is more severe than strap muscle extension, that is more severe than minimal extrathyroidal extension, and obviously no ETA is the best situation you can find. This is telling us probably we should remove strap muscles, at least sternothyroid muscle together with the thyroid. Microscopically positive margins are required to be known, especially in the anterior or posterior part of our dissection. Age has been shifted from 45 to 55 years. We all know that patients under 55 years go very well, even better than the others. Subtypes of PTC have changed just a little bit, as we previously said. Somatic genomic testing will be taken into account afterward in selected cases, and the oncologists have already spoken about them. Sex might have a weight in the recurrence risk establishment, in the recurrence risk calculation, because the male population goes worse, behaves worst. And also body mass index is will be probably taken into account in the next guidelines. This is very well written in the current guidelines. Clinical response to surgery will be assessed exactly the same way. Thyroglobulin, excellent response, indeterminate response, biochemical incomplete response, and structural incomplete response, as it is right now. But we have an issue, because we might have a lobe inside the neck. So thyroglobulin after total thyroidectomy is one thing, thyroglobulin after lobectomy is another thing. Thyroglobulin after lobectomy is supposed to be done once, just to establish that there is no high level, unjustifiable high level of thyroglobulin that would indicate completion thyroidectomy immediately. 4 classes, again, of response criteria. They are very well stressed. They are very well stressed, and they include all patients that have been operated on, even for total thyroidectomy or for lobectomy. We should modulate our follow-up upon the extension of surgery. Everything is changing. How about ablation? Okay, my nuclear doctor wanted to be sure that I would behave right here, right now. So he gave me just a few indications. First of all, we can ablate intermediate risk of recurrence patients, but we should not rush. There is always time to indicate radioactivated ablation. But if we performed a lobectomy and we have an intermediate high risk of recurrence patients, we need to complete him first or her first. So very often radioablation require completion thyroidectomy, and the two things, those two situations go all together. But we should not rush toward RAI treatment. Is it possible to de-escalate, to tell a patient, okay, you're cured, Yes, especially for very low-risk patients that have been followed for 10 years, 8 years, 10 years, but I think also 5 years after surgical lobectomy for low-risk tumor, the patient can be considered cured. So the follow-up can be restricted in these cases. When we talk about persistent or recurrent disease, we should always keep in mind the DATA approach. So DATA is what follows throughout all the guidelines. Disease diagnosis, assessment, treatment, assessment. It's not necessary to rush on a treatment if the treatment is not dangerous. I mean, no one died of a thyroglobulin with a thyroglobulin of 16, but no one died also for a thyroglobulin of 60. So no rush. Take your time. Re-evaluate the patient over time. Consider doubling time, and then assess the patient and treat if needed. What my nuclear doctor wanted to stress: don't give RAI with the purpose of burning that 12 millimeter lymph node in the central compartment. It won't disappear. It will stay there, and it will not probably be the cause of death of your patient. Refractory, RAI refractory DTC is another, totally another topic, and has been already covered by my previous lectures. So take-home messages: we need to learn a new pathologic system. Those pathologists are always wants us to keep young our minds and to remind a lot of acronyms. Okay, we know, but now we know that NIFT-P can be easily considered an indolent tumor, if not a benign tumor. After we have learned the acronym, we know that NIFT-P is not dangerous at all. Take a look at oncocytic thyroid cancer. Oncocytic is a different beast. Oncocytic is more severe than other papillary cancers. The clinical scenarios are so wide that we allow us to tailor the treatment on the patient. So these guidelines, if we search for an answer for our patient and we search on the guidelines, we won't find the answer probably at a first sight. We need to interpret every part of our patient: final histology, preoperative workup, ultrasonography, CT scan, whatever, PET scan. And we will deal with it with a very slow attitude. And then we will find the answers. How to deal with them with the help of our multidisciplinary team, which is essential for us. The use of RAI will be completely reassessed, meaning that it's creating a great confusion in people who wants to perform RAI in every single thyroid cancer case. What I have to say is that surgical strategies are really clear for low risk, very low risk tumor, are extremely precise for high risk tumor, but in the indeterminate situation. So the very most part of our clinical activity, they can be really confusing if one doesn't know how to deal with it. Okay, I stop here with these photos. The one of you who had the opportunity to know these two mentors know that they were really asserting And Professor Pinquera, once I've heard him personally saying, guidelines are for dummies. Do you need guidelines to do your work? You're not an expert in thyroid cancer. And that's exactly what these guidelines say. They leave us a strong amount of tailoring both because of the patient and also in our practice, for our work during our individual clinical life. And I thank you very much for your attention.
Thank you, sir. Thank you very much for excellent narration about the guidelines, which might have cleared almost all the confusions in the audience. Thank you very much again.
Thank you.
Thank you so much, sir. Now, I would like to call on stage Dr. Jyoti ma'am, Dr. KK sir, and Dr. Kaustubh sir to felicitate Dr. Michael. I would like Dr. Kaustubh sir to please felicitate Dr. Michael with a stole. And I would like to ask Dr. KK sir to give lifetime membership certificate to Dr. Michael.
I just read this first.
Again, this is a certificate title with the society name, Indian Society of Thyroid Surgeons, honorary membership certificate. Be the undersigned hereby declare that Dr. Michele Minuto is awarded honorary life member of the Indian Society of Thyroid Surgeons. As such, he shall enjoy the privileges and be subjected to the obligations of the membership of the society, whose objective is to promote the science and practice of thyroid surgery. Signed by Dr. Jyoti Dabolkar, Dr. Madan Kapre, and myself.
So the people who are in the hall Bilrot at the back end in the dinner table arrangement, they are requested to empty their chairs because the halls are getting separated. In the meanwhile, if you have any questions for Dr. Minuto or comments or suggestions or anything that you wish to say, please, we have 5 minutes of discussion that we can undergo.
Excellent insight about new ATA guidelines, Dr. Minuto. One thing which I distinctly felt is that there is a new guideline for the surgeons also now, that a surgeon who is doing more than 30 thyroids should dabble with this. Now there is a dichotomy to that. And when we talked about the volume of thyroid patients, particularly in European countries and US countries, and when you are capping the surgeon who is doing more than 30 only, how you deal with that volume, and what are your suggestions for training new thyroid surgeons? Because now it's a dichotomy. You don't want them to operate, and at the same time you want them to get trained. So what is your answer to that?
Well, this is an excellent question, and we do not have an answer. The thing is, less and less surgeons, in my opinion, want to become thyroid surgeons. I don't know why, but in Italy, less and less wants to become endocrine surgeons. So we have a very few. How to deal with them? I try to send them patients. I want to keep centralized the oncologic diagnosis to perform surgery for thyroid cancer. This helps me in my national registry and for my experience. And on the opposite side, I do not have time for benign nodules, for benign thyroids, for benign goiters. So I try to educate other surgeons coming from my region to perform surgery on more selected cases. I see a lot of patients, I send them those I think they can deal with, trying to avoid, to be educated enough to avoid giving them a horrible Graves' disease and giant goiters. But in my opinion, they should start doing the surgery after spending a few times in whatever center, high volume centers they want. That is essential. First, see how to do it, and then someone should give you the cases. I am the one who can give you the cases. I don't know how to operate my patients, so I give them a lot of